Hello and welcome back to Communicable for our first episode of 2026. Communicable is brought to you by the journal CMI Communications, ESMID's open access journal covering infectious diseases and clinical microbiology. My name is Annie Joseph, clinical microbiologist at Nottingham University Hospitals in the UK and associate editor at CMI Comms. Co-hosting with me today is Josh Nosanchuk, fellow editor at CMI Comms, infectious diseases clinician and professor of infectious diseases and microbiology and immunology at Albert Einstein College of Medicine in New York City. Hi, Josh.
Hi, Annie. Thanks for doing this with me today. We're really excited to welcome two outstanding guests to discuss meaningful papers in clinical microbiology published in 2025. The first guest is a rock star in infectious diseases and medical microbiology, my friend Robin Patel, the Elizabeth P. and Robert E. Allen Professor of Individualized Medicine, Professor of Microbiology, and Professor of Medicine at Mayo Clinic in Rochester, Minnesota. Robin is the Director of the Infectious Diseases Research Laboratory at Mayo Clinic and co-director of its Clinical Bacteriology Laboratory. Robin, welcome to Communicable.
Thank you, Josh and Annie. It's my pleasure to be here.
Our second guest is a super awesome member of ESMID's executive committee responsible for education and the affiliated societies, and a terrific resource for music suggestions. Fidelma Fitzpatrick is the head of the Department of Clinical Microbiology in the Royal College of Surgeons in Ireland, University of Medicine and Health Sciences, and a consultant clinical microbiologist in Beaumont Hospital, Dublin. Thank you for joining us on Communicable, Fidelma.
Thanks very much, Josh, and thank you, Annie.
So as our listeners know, we like to start with a get to know you question. The question this week is, what is the most memorable or strangest thing that has happened to you in 2025? Robin?
Well, I'm going to tell you about a couple of papers and something that I don't often talk about. So we got some special funding from the Centers for Disease Control and Prevention in the Pathogens Genomics Centers of Excellence program. And our work is naming the unnamed. And so we are naming previously unnamed bacteria that we encounter in the clinical microbiology lab that really stump us and put us in a difficult position because we can't issue a report for an unnamed bacterium. And naming bacteria, for anyone who's done that, is quite a task. So we were very thankful to get funding from the CDC to do this. And this past year, we described 4 new species. And I also want to tell you about the naming process because that was something that I learned something about, not just the sort of what name is allowed and so forth, but the names we chose. So we described Corynebacterium mayonis and Dryocola mayonis, but then we described 2 other Dryocola species, and I couldn't use that same Mayo Clinic associated species name. So we decided to name 2 prominent microbiologists. So there's a Dryocola sharpie and a Dryocola bayroni, and they're named after Susie Sharp and Ellen Jo Barron, respectively. And that was very exciting to be able to name microorganisms after famous microbiologists.
That's so cool. And Fidelma?
On a personal level, I was sick last year and I came back to work and I started working with ESCMID, and it reminded me how fantastic my colleagues are and how fantastic my friends and family are. And I suppose as a doctor that works all sorts of hours, it's important to remember what really supports you and enables you to do your job. The research that I was most proud of this year is one of our hospital staff, Mairead Scally, sat down with patients and asked them about their experience of hospital infection and AMR.
Fantastic. For the first episode of this new year, we've asked our esteemed guests to select top 3 papers published in 2025 in the field of clinical microbiology, papers that they found interesting or impactful. And the papers are extremely varied, as is the field of clinical microbiology itself. And we'll be going from the lab to the ward, some epidemiology, science communication, and even back in history.
Okay, so Robin, you're up first. The microbe that you'll be discussing is named in honor of the amazing microbiologist Elizabeth O. King, who worked at the CDC, and she named the pathogen in 1960s, though it was first called Moraxella kingii. Robin?
Thanks, Josh. So I picked this paper that was published in the Journal of Clinical Microbiology called an in-house Kingella kingi PCR in a large pediatric cohort, impact on diagnosis, antimicrobial stewardship, and clinical outcomes. And I will say it was really hard to choose just 3 papers. But I'll tell you why I chose this one, and actually all of them have a personal connection. Kingella kingi is associated with bone and joint infections in children. And I was part of a team that designed the Kingella kingi PCR assay that we run here at Mayo Clinic, and we've been testing since 2017. And I think we've learned a lot, and this study is very well done and emphasizes a lot of what we've learned in our own clinical practice that I think is important to share with the broader community. So the objective of this study was to characterize the performance of a Kingella kingi PCR and determine its impact on antimicrobial utilization and clinical management in children. It was carried out from 2014 to 2024 in children who had Kingella kingi PCR performed, and it was done at Nationwide Children's Hospital. Testing there was offered once daily. During the study period, 500 children had the test performed, among whom 45 had a positive result by PCR or by culture. So compared to clinical diagnosis, the Kingella kingi PCR had a sensitivity and specificity of 96 and 100% respectively, super high. There were 44 patients with positive PCR results who were simultaneously tested by culture, and among them, 36 were culture negative. There was only one patient who was culture positive and PCR negative. So PCR improved case identification by 4-fold compared to culture. So I think that's really important. Most of the kids in this study were previously healthy, afebrile, and the clinical presentations included mostly septic arthritis and acute hematogenous osteomyelitis. Now, all the children were classified into a group called less than or equal to 5 years old. I have a little issue with the authors on that. I think lumping all children into 0 to 5 years is kind of a broad age group, but I'll come back to that in a minute. That's just how they designed their study. In this group of less than or equal to 5 years old, though, Kingella kingi was the most common organism detected, more commonly than Staphylococcus aureus, causing bone and joint infections. And that's a very important message and consistent with what we see in our clinical practice. But the piece about the age, I think, is important. So the median age was 18 months, and all the children were 1 to 3 years old. So it's not really 0 to 5 years. It's a much narrower and special window. Although not all the organisms grew in culture, they did do some susceptibility testing on Kingella kingi isolates, and they were all susceptible to trimethoprim sulfamethoxazole, meropenem, ciprofloxacin, levofloxacin, ampicillin, amoxicillin, clavulanate, penicillin, and azithromycin, and they were all beta-lactamase negative. And that's important in terms of selecting antimicrobial therapy. The median time to result for the PCR was 27 hours, and 84% of subjects had antimicrobial modifications made within a day of that PCR report, resulting in de-escalation in most cases. The children were treated for this infection for a median of 21 days, and all had complete resolution of symptoms, also very important. So my takeaways are that Kingella kingi is the most common cause of acute septic arthritis and acute hematogenous osteomyelitis in children 1 to 3 years of age. In my mind, PCR is the incontrovertible test of choice for these children if you're trying to make a diagnosis. In the United States, there are no FDA-approved standalone tests available to these children. And for that reason, testing for these children is not widely available. And that's a problem. Clinical outcomes, fortunately, are excellent. In fact, that leads me to ask some questions. Do these children need any surgical intervention? Do they even need to be hospitalized? And how long do they need antimicrobial therapy? They got a median of 21 days. That seems long. Is that really needed? All questions for future studies. So I loved this paper. I think this is really important to those 1 to 3 year old children who are affected by this particular organism, and obviously to their parents as well.
Yeah, it's such a cool paper, Robin. And I think the access to molecular diagnostics is really helping us to understand epidemiology in a different way. Particularly, it's not 0 to 5, it's really less than 3, and maybe median age is about 18 months. It does make me wonder, though, what is going on around that time immunologically? Is it a first exposure to Kingella kingi? Why is it this age range that seems to suffer with this pathogen?
Yeah, that's a really good question. There are several infectious diseases in children that manifest at a specific age. For some of them, I think we can say we maybe know that answer. And for others, at least I don't know that answer. When I thought about that idea, the closest organism that I could come up with was Haemophilus influenzae. So I trained in an era before the Haemophilus influenzae vaccine. And at our children's hospital in Montreal, it was just full of kids infected by Haemophilus influenzae. By the way, it was a disaster. Like, the outcomes were very bad. And the vaccine just turned that whole thing around. But, Haemophilus influenzae affects a slightly younger population than Kingella kingi. So I don't think we can directly translate what's going on. But it must be some combination of immunity. So there must be some protective immunity that's coming from mom, I'm guessing. There must be an exposure factor that they're being exposed to this organism. Certainly, respiratory transmission in daycares has been reported. So that may be playing a role here. But then the other thing that's, I think, really interesting and that I don't have an explanation for is these are bone and joint infections, and just bone and joint infections for the most part. I have a hard time thinking of another organism that does exactly that. So there must be something about the bone and joint space in this age group of children that is making them at risk for these infections. But I don't know. Josh, do you know the answer to this question?
I don't. I think it's really interesting, the physiology of bone and how fast it's remodeling. The epiphyseals don't fuse until you're much, much older. So it's not that's keeping the 11 and 12-year-olds from having this. It's really fascinating. I do also think that the fact that this was done in North America is important to highlight, like you said, Robin, because certain places like in Africa where they see salmonella in small kids is important. And so when you're coming up with your design, you have to take into consideration where you are. Things are getting closer globally in some things, but not in some of these other areas like salmonella. So another twist.
That's a really good point, Josh. And I think you touched on it, Robin, about the prevalence of fever in the Kingella kingi group. That surprised me. Less than a third had a fever, and the median CRP was only 2.9, which was a take-home message for me, really thinking about these aren't necessarily sick, unwell kids. They're presenting probably quite generally well, but with an acute bone and joint infection at the right age range. So, yeah, can maybe target testing towards the right kids.
Yeah, so they didn't really tell you whether they just had a limp or they weren't crawling as well, like what brought them in versus a Staph aureus septic joint. So interesting to get more information about the individual presentations. That was really an interesting conversation. We're going to stick with you, Robin, on our second paper, which is more of an epidemiological slant. What have you chosen?
This next paper that I chose comes from Lancet Microbe. It's called Invasive Streptococcus dysgalactiae subspecies equisimilis, compared with Streptococcus pyogenes in Australia, 2011 to 2023, and the emergence of a multi-continent STG 62647 lineage, a retrospective clinical and genomic epidemiologic study. So Streptococcus dysgalactiae subspecies equisimilis is closely related to Streptococcus pyogenes with overlapping disease manifestations. I picked this one because this is something that I've observed in our clinical practice. We run a 16S ribosomal RNA PCR sequencing assay on normally sterile body fluids and tissues. And I see this organism frequently. In fact, I just pulled data from 2024 and 2025 to date. The numbers of strep pyogenes detections were 123 and strep dysgalactiae were 92. So they're pretty similar. That I think is maybe something that's under-recognized in clinical practice. I also lumped Streptococcus agalactiae into this, and we detected 155. That's not the topic of this paper, but it might be something for clinicians to think about when they think about beta hemolytic streptococci. So back to Streptococcus dysgalactiae subspecies equisimilis and Streptococcus pyogenes, the two share niches in the human throat and skin, and they're thought to transmit via a respiratory route or maybe direct contact. But like I said, I think clinicians know a lot about Streptococcus pyogenes, group A strep, but maybe not so much about Streptococcus dysgalactiae. This Australian study compared the clinical and genomic epidemiology of invasive Streptococcus dysgalactiae with invasive Streptococcus pyogenes and phylogenomically contextualized Streptococcus dysgalactiae sequences against a global cohort of genomes. So invasive Streptococcus dysgalactiae isolates from normally sterile sites were identified and sequenced across hospital networks in Melbourne and Sydney, Australia, and the Northern Territory of Australia. Genomic transmission clusters were inferred between isolates from different people by single linkage clustering using a single nucleotide polymorphism threshold of less than or equal to 7 for Strep dysgalactiae and less than or equal to 5 for Strep pyogenes. The study was carried out on isolates between 2011 and 2023, and there were 693 invasive Streptococcus dysgalactiae and 995 invasive Streptococcus pyogenes cases, so not too dissimilar. Invasive Streptococcus dysgalactiae occurred almost exclusively in adults, so now we have an adult infection here. 30-day mortality, in-hospital mortality, and ICU admission were similar across the two species. The overall incidence of invasive Streptococcus dysgalactiae in Melbourne and Sydney was very much like that of invasive Streptococcus pyogenes. Interestingly, in Melbourne and Sydney, where COVID-19 mitigation strategies were enforced in 2020 and 2021, they witnessed a plateau of the number of cases of Streptococcus dysgalactiae, but a decline of the number of cases of Streptococcus pyogenes, suggesting differential effects of those strategies on the two species. In the Northern Territory, Streptococcus dysgalactiae incidence was lower than Streptococcus pyogenes incidence, but higher than in Melbourne and Sydney, and disproportionately affected First Nations Australians. Also, in the Northern Territory, where COVID-19 mitigation strategies were not implemented like in Melbourne and Sydney, rates of infections with the two species did not change during the pandemic. Now, looking at the whole genome sequence data, only 6% of Streptococcus dysgalactiae cases were assigned to genomic transmission clusters, compared to 52% of Streptococcus pyogenes cases. 1/4 of the Streptococcus dysgalactiae genomes belong to an STG62647 lineage. Analysis then of sequences not just from Australia, but from Europe and North America showed international expansion of this lineage in all three regions between 1990 and 2005. This lineage is estimated to have emerged in the first place in 1956 or so. The conclusion of this study is that in high-income regions, invasive Streptococcus dysgalactiae is just as prominent and common as invasive Streptococcus pyogenes infections, and is dominated today by a global lineage. I think this might be an under-recognized pathogen globally, at least amongst clinicians. I think a lot of us weren't trained to think about these two strep species in this way. That few cases were assigned to transmission clusters, and that cases did not decline with COVID-19 mitigation strategies different than Streptococcus pyogenes suggests that the two species behave differently. Invasive Streptococcus dysgalactiae may arise from long-term carriage rather than acute transmission like Streptococcus pyogenes, but more work is really needed to understand carriage and immunity and molecular drivers of emergent lineages to inform potential disease management and control measures.
I don't think microbiologists help ourselves particularly with the naming of these species. Robin, when you were saying about everyone kind of knows Strep pyogenes, I mean, pyogenes tells you what it is, like the name's on the tin, isn't it? Whereas we've got Dysgalactiae, Agalactiae, like I just don't think clinicians generally have a feel for what Strep dysgalactiae subspecies equisimilis is and does. I'm still kind of a little bit old school and have that thought about it's a group G strep and G for geriatric. And I just kind of remember that. And actually these patients were older on average than the Strep pyogenes cases, weren't they? So I think that's possibly true, but it kind of surprised me that the incidence overall was very similar to Strep pyogenes. I want to know what it is in the UK. I did try and look it up after reading this paper, but it surprised me.
That's why I chose it, because like I mentioned in our own experience, I was a bit surprised because based on our sequencing work, it's kind of on par with Strep pyogenes for these invasive infections. This is Australia. We're in the United States. I think other people should maybe look at this. I bet that's what's going on in other areas. You're absolutely right. We in the lab were probably a bit to blame for this. The reason is that we've changed the way we identify organisms and we report organisms. That has maybe led to a lot of confusion over time. because there are strep that are closely related to Dysgalactiae that are not necessarily human pathogens, right? And so I think now that we can better identify these organisms, and MALDI-TOF mass spectrometry works just fine, we should be able to better identify these organisms, and then that should better inform clinical interpretation and pathogenicity. But there's a lot of confusion on the naming side of things, as well as on the interpretive side of things that goes on here. So that's why I think this is important, recognize this species, Streptococcus dysgalactiae, as a very important human pathogen.
I was struck by how many individuals had recurrent infections in both of the species, and the finding that with the Dysgalactiae, they had more likely to have the same recurrent one, whereas Pyogenes was often different. But the fact that these individuals are having multiple ones, when most people never have a significant strep infection at all, makes me wonder, is there an immune process in these individuals that makes them more susceptible to this particular disease? And also, they didn't give us much information about toxin production of this lineage and whether it's a high toxin producer or a low toxin producer, or if those that had recurrent, even though it's the same lineage, if they had variants that were higher or lower producers of various streptolysins and superantigens. So I think there's a lot more that we need to learn that may help explain some of the disease processes that they're reporting here.
I completely agree. And the fact that they have all that genomic data might mean they could dig a little bit more around those pieces. But I really chose this just because I think it starts with the lab identifying and recognizing that this is an important pathogen and reporting as such, and then clinicians interpreting in that way. Then we need to get to the why, like why these people are getting infected, how they're getting infected. Can we do something to prevent these infections? Can we better manage them so that they don't have recurrences? And what will that involve? What do we need to be doing? Is it more aggressive surgery when surgery is performed? Is it different antibiotics, prolonged treatment, adjunctive therapies? Lots of questions that we can now ask. But until we begin to identify these properly in the laboratory and then understand that they are significant pathogens, we can't even get to that point.
Again, argues for why clinical microbiology is vital.
Definitely.
In many places in the world, the next two papers might be seen as more strictly in the sphere of ID rather than Clin Micro. However, in a lot of countries like Ireland, where Fidelma practices, and the UK, where I do, clinical microbiologists are quite patient-facing rather than purely in the laboratory, and the lines between the two specialties are much more fluid. And CMI Comms and ESMID is for all of us wherever we sit along this clinical spectrum. So, Fidelma, you've chosen first the DOTS trial, which is dalbavancin for the treatment of Staph aureus bacteremia, published in JAMA in August 2025. And interestingly, these trial results were presented at ESMID Global back in 2024 in Barcelona in the late breakers session, and were discussed on our very first episode of Communicable, which was the Late Breakers Trial Roundup. So listeners can go back and check that episode out if they haven't already listened to all our back catalogue. So obviously it's taken quite a long time from conference presentation to publication. And I know many people who insist on waiting for the full publication before changing their clinical practice. So Fidelma, over to you.
So I chose this for a few reasons. First of all, this is common. We see a lot of patients with Staph aureus bloodstream infection. Certainly in the Irish healthcare system, we are at capacity in our hospitals. So anything that aids safe and earlier discharge is a good. And having recently been a patient and had several IVs in, anything that stops me having lots of invasive devices is a good thing. So that's the preamble. So this was a randomized trial, and there was two arms. The patients either got dalbavancin or they got standard therapy for complicated Staph aureus bloodstream infection or right-sided endocarditis. So there was 22 hospitals in the US, one in Canada, and it ran from April 21 to December 23. And importantly, patients were enrolled after their blood cultures had cleared. So we're now comparing consolidation treatment. So these are very stable patients. So what attracted me to this is when you think of standard therapy. Standard therapy means having to get a PICC line in, which is not much fun, keeping a PICC line in for 4 to 8 weeks. It may limit your mobility, and it certainly carries risks like clots and secondary infections. Even just simplistically, it's kind of a no-brainer from a patient end of things to have 2 short IV infusions on day 1 and day 8. When you can go home and carry about your normal life. So the investigators, not surprisingly, expected dalbavancin to reduce side effects and improve treatment completion and enhance quality of life. And surprisingly, it wasn't superior to the other arm, and I'll go through how they measured this in a minute, but it was non-inferior for efficacy, so it was equally as good and it was equally as safe. The bottom line for this is it got me thinking and got my colleagues thinking that actually this may offer a way to finish therapy without the hassles and the hazards of prolonged IV access. While it's not better than standard care, and what they talk about standard care is if you had a methicillin susceptible staph, you got an anti-staphylococcal penicillin or cefazolin, and if you had an MRSA, Vancordapto. So that's the comparison, but it was equally as good. Going through the trial, who were they? Well, they were adults over 18. And what's important here is who is included. The definition of complicated Staph aureus bloodstream infection was essentially people that were not uncomplicated, if that makes sense. So I had to reread that sentence a little bit myself. So uncomplicated bloodstream infection means you don't have endocarditis, you don't have an implanted prosthesis, your follow-up blood cultures are sterile, and your fever has settled and you don't have a secondary site. So you're not that. But then when you looked at the exclusion criteria, there was lots of patients that I would see that I would have called complicated Staph aureus bloodstream infection that weren't included. So more double negatives. So CNS infection, not surprisingly. And patients with left-sided endocarditis weren't included, or perivalvular abscesses. If you had any sort of prosthesis in you that couldn't be pulled out, you weren't included, be it heart valves or prosthetic joints or prosthetic grafts. So I think that's important when we carry on to talk about the results, that while these are complicated Staph aureus bloodstream infection, it's a limited subset of complicated patients. Now, from a laboratory bit, it was interesting. They did what we all did up till recently. They inferred dalbavancin susceptibility from the VANC susceptibility. And the recent UCAST update has told us we shouldn't be doing that. We need to check our dalbavancin susceptibilities, and that's what we're currently doing ourselves. The primary outcome was another acronym. It was a thing called the DOOR criteria. So I obviously like my dots and my doors. So what DOOR was is, I think it's quite interesting. It was a composite endpoint, and it was much more patient-centered than being cured, alive or dead. And there was 5 elements. It was clinical success, whether you had infectious complications, safety complications, mortality, and then health-related quality of life, which when we're talking about dalbavancin, I would have thought is kind of important. And the health-related quality of life was measured by patient-reported health status. So the highest DOOR ranking was if you had treatment success, ta-da, and you had no complications. And the lowest DOOR ranking was if you died at the study endpoint at day 70. And there was bits in between. So I thought this was an interesting primary outcome when we look at this, because you kind of would inherently think, because you don't have a PICC line inside you, that health-related quality of life, it might skew it to favour dalbavancin. The bottom line, as I said, it was non-inferior, and there was 200 patients, 100 in each group. Only 10, though, had right-sided endocarditis. And again, I had to reread the way they reported the outcome, because it's kind of a probability thing with the DOOR criteria. So the probability of dalbavancin being superior was 47.7%, which meant it didn't meet superiority criteria. So then I thought, if you randomly picked somebody out of the dalbavancin group, they were 47.7% likely to have a better overall treatment outcome than somebody selected from the other group. Now, to the investigators' surprise, when they broke down all the 5 DOOR criteria, the health-related quality of life was very similar, which was interesting considering what I said in my first preamble, that you have a choice between a PICC line or a peripheral line. So maybe actually from a patient end of things, the way an antibiotic is delivered isn't as important as we all thought. Personally, I would have thought so, but that's the results. Or else maybe just the criteria and the questions we asked weren't the right questions to ask. And they go through that a bit in the editorial. So being very dutiful, I pulled all the supplementary material and went hunting for the DOOR criteria because I couldn't figure it out. And in one of the supplementary, some of the questions they asked is, could you go up and down stairs as normal? Can you walk at least 15 minutes? Can you do some chores? Can you run errands? And you probably can do that with a PICC line as well as not. So I just got me thinking maybe sometimes when we're asking questions, we need to be more specific. So while it didn't show superiority, it did confirm similar outcomes. So it means that from a patient perspective, there's practical benefits. You're not having a PICC, you don't need OPAT. And if you were on vancomycin, which we wouldn't ever prescribe on OPAT, but some people do, you don't need vanc levels. You don't have people coming into your home. You don't have a risk of thrombosis, etc., etc. But it's important, again, to look exactly at the types of complicated infection that we're talking about. So while it's complicated infection, there's lots of exclusion criteria. But I like this trial because it's got us talking in my own hospital about this expensive drug. We probably need to start getting better at the full health economics argument. But I do think it's a reasonable option for completing therapy. And that's the trial. Dots, doors, and give dalbavancin a go.
Thank you. A population that you sort of referred to when you said going home. We have, unfortunately, too many unhoused individuals. And unfortunately, some of those are at high risk for these staph aureus infections. And it's always complicated how to address their long-term care. And switching to orals early is certainly something that we've been pushing a lot, but especially in this population, this type of approach is something that is life-changing for those individuals. So I do want to recognize that.
15% of their patients were intravenous drug users, and you're absolutely right. Anything without a device is obviously best, but oral medication are not without their issues either. Like, you actually have to take them. And if anybody's ever tried to take TDS or QDS, so 3 or 4 times a day, you kind of need to be a ninja on your timing. So I agree with you. We too have a group of patients that don't have a home to go to. And for other reasons, then this is also a good option because they'll at least get one dose. And the dose they're using is 1.5 grams, so 1,500 milligrams. So it's a high dose.
Yeah, we also have individuals who can't stay in the hospital longer because they have no childcare and other issues like that. And so in the US, it's very hard in some of these populations to set up home infusion. And so this is really a life-changing opportunity to administer this. I will circle back to ask about the economics because that is in many countries what really drives some of the decision making. And they did not really analyze that in this paper. And I'm wondering what your thoughts on that are.
Yeah, like I think the drug cost, but also the OPAT comes with a cost too. I kind of had a look in Ireland. So if the dose they're using, it would probably be about €1,500 for one dose, so about €3,000 for the course. But OPAT also costs money. And you have to pay staff, and you have to pay staff to go there and pay their expenses. You have to pay for the drugs, never mind the poor patient and people coming into their home. So everything has a cost. But that does not take away from the fact that these are costly drugs. But I do think that if we're going to try and move this forward, we need to be a bit more holistic about how we talk about cost. We also need to bring in our health economists and our patients into this research, because the health economists can talk about the euros or the dollars or the pounds, but actually maybe our patients also need to start telling us about their quality of life and what they can't do, and can they go back to work, and do they have to stay at home, and what have they lost? I don't have the answers to that, but yes, it's an expensive drug, but the other options don't come without cost either.
That's a really good point. And I think the setting in which the health economics are done in is going to be crucial, really, isn't it? Because the NHS in the UK and Irish system compared to the States, you know, it's just a completely different kettle of fish, isn't it, in terms of whether this will be cost effective and how that's spread across the healthcare system. It's much easier when you're in a public healthcare system where costs are spread across everybody. Cost savings are spread as well. Yeah.
But I suppose, like in Ireland, we have a mixed public and private system. At the moment, the way OPAT is funded, it's funded separately from the hospital, and it's slightly different from the UK. For example, unlike the UK, a lot of our GPs are private, but they're contracted by the Public Healthcare Service to look after patients. If I had to think about this in our hospital, to do this, you would have to have a daycare facility or a day ward, So to bring your patient in so that they can safely get an IV stuck into them and sit there for their hour or so and get their infusion. So that's not rocket science, but you still need to have that facility. Or else get your OPAT team trained up to be able to put in a peripheral IV and administer it at home. So there's certain ways to crack this nut. But I agree with you, we do need to be much more holistic in the way we talk about cost. And maybe that's an idea for 2026.
Fidelma, thank you for picking this article. It was executed by the Antibacterial Resistance Leadership Group. And just to declare my conflict of interest, I am the laboratory center director for that group. I think that's important because we need to be looking at this kind of studies. And I think sometimes we, as physicians, we think we already know the answer to the question. And so the patient perspective highlight that you brought out, we thought we already knew the answer to that question because we applied our physician's perspective to that. And we said, well, patients will prefer this because that's what I would prefer. But in fact, you're right. Maybe we didn't ask the right questions, but maybe we're also not the right people to answer those questions, that we need our patients to answer those questions. So it's very nice that you picked this paper. And I think it showed a lot, but we also learned a lot about study design and the importance of the patient perspective.
All right, we're going to change the game here. The next one up is another clinical trial that has only been published this year in October in Lancet Infectious Diseases, after also being a late breaker in Barcelona in 2024. And it's the Game Changer trial. Fidelma, can you give us some more information about this?
I like my tabloid acronyms, but I also heard David Patterson speak in the Gamma conference in London, and I must say he's one of the most fantastic, engaging speakers I've ever come across. So then that piqued my interest along with the Game Changer trial. So what is it? So it's Cafidricol versus standard therapy for patients with either hospital-acquired or healthcare-associated gram-negative bloodstream infection. And this was an open-label parallel group randomized trial, and it was in adults. So it was all gram-negatives, but it did include carbapenem-resistant organisms. And importantly, patients were randomized within 48 hours of blood culture collection, which I don't know about any of you lot, but I thought that was pretty fast, so wow. What they were trying to find out is whether or not Cafidricol was either non-inferior or superior to standard therapy in terms of survival and infection clearance. The gram-negative bloodstream infection has a very high mortality, especially when you get to being carbapenem resistant. 1 in 3 patients will die at 30 days. Even third-generation cephalosporin resistant Enterobacterales, just under 10% of people die. So this is an issue. So Cafidricol is one of those Trojan horse antibiotics that, since it's first come out, certainly in my hospital, we've been scratching our heads trying to figure out when we should use it. The bottom line here is, I'm still not sure, but I'll tell you about the trial. And definitely there was, from previous trials, there was a little bit of concern about, should we really be using this in carbapenem-resistant organisms? But this trial looked at all gram-negatives. So it was a big trial, started at the end of 2019, finished towards the end of 2023. And it was in 17 hospitals between Australia, Malaysia, Singapore, Taiwan, Thailand, and Turkey. And they were adults. Interestingly, adults are over 21 in Singapore. The rest were over 18. And to get in, you had to have a gram-negative bacillus on your gram stain. And in terms of exclusion criteria, just, I suppose, for me, importantly to remember, patients that had vascular catheter-related bloodstream infections where the catheter stayed in were not included, as were palliative-type patients. And patients, as I said to you, were randomized within 48 hours of blood culture collection, which means in practice, you're probably not going to have known the susceptibility. And that's probably why the investigators allowed a second antibiotic to be combined with Cafidricol until it was confirmed as susceptible. So the primary outcome this time was a bit more straightforward in terms of getting your head around. It was all-cause mortality at 14 days from the date of randomization. And there was a number of secondary outcomes as well. In terms of the results section, they screened a lot of patients, over 9,000 patients. So despite this being a common infection, certainly in my practice, they had to screen a lot to get 504 patients, 250 in the Cafidricol arm. Now, when you look at, I think it's one of the tables, or maybe it's one of the supplementary tables, their standard of care antibiotics is a bit of a mishmash. So there's carbapenems, there's Piptazo, which we certainly commonly use in my hospital for healthcare associated gram-negative bloodstream infection, cefepime, and a bit of aminoglycoside use. But for me, maybe it's to do with the timing of the trial, there was very few patients got the newer beta-lactamase inhibitors. So in our practice, if you think somebody possibly has a multi-drug resistant gram-negative and you see a gram-negative on gram, you probably would go in with Keftaz-Avi. That's kind of ours. So in terms of the population, the sources of gram-negatives, I was surprised that only 19% had a UTI. I think they talked about that in your first podcast as well. And the rest was pretty kind of what we'd expect in our practice. The gram-negatives were E. coli and Klebsiella. So for me personally, they were quite representative of the patients I'd see. What I don't see is 1 in 4 patients had a carbapenem-resistant organism. So that to me was, whoa, that's definitely not what I'd see in our population. When I started trying to extrapolate these patients, about 27% had a third generation cephalosporin resistant Enterobacterales. So in Ireland, just to put that in context, about 12% of our E. colis and 15% of our Klebs have a third generation Kef resistant. So it's slightly different to my context. And when we looked at the carbapenem resistant organisms, there was only 4 KPCs, 26 oxas and 58 metallobeta-lactamases. So if that's your population, that's fine, but that's definitely not our population. And the primary outcome of the all-cause mortality after all of that is, drum roll, there wasn't much difference. So at 14 days, 8% versus 7% for Cafidricol and standard therapy. So they were similar. But when we looked at the carbapenem-resistant organism subset, there was a slight difference, but the numbers are very small, 14% versus 10%. But what that actually is 9 patients versus 6 patients. And with the MBL, the difference was, again, larger, but small numbers. So it was 31% for Cafidricol mortality versus 0%. But we're talking 5 out of 16 versus 11 patients. So that's what I mean, like, I'm not really sure what to do with this drug. The other thing that I thought was interesting, and maybe it's just because of my recent patient history, when I looked at the table 3, it just reminded me how sick and debilitated these patients are. Because when you looked at their functional status at the end of the study on day 30, only 36% and 39% were described as out of hospital and basically healthy. So this study showed that Cafidricol was non-inferior but not superior to standard of care, bearing in mind that was a mishmash of lots of stuff, based on a primary outcome of 14-day all-cause mortality. And we're still really not sure what to do in carbapenem-resistant organisms. And to be honest with you, I wouldn't be using Cafidricol straight off in a gram-negative on bloodstream. I'd probably use either Piptazo if it's healthcare. If I was worried about resistance, I may add an aminoglycoside. If I was worried about carbapenem resistance, I'd probably use Keftaz-Avi. And while this study is fantastic and really well designed, it hasn't changed my practice.
That's fabulous. The first thing is we pronounce the drug differently.
I was going to say that. I was going to say, we should have talked beforehand. How are we all going to say it? Because I'm going to say it totally different.
I'm going to do it now as Fidelma does. But I think your comments on selection of drug is really important. And the authors do state that they recognized it as well. They said very few patients in the standard of care group receive the newer beta-lactamase inhibitors, such as the Keftaz-Avi. So I think they are in the same camp as you on that. Another area was on source control, that they didn't have data on that. That was super important too for me.
Yeah. They go through the discussion. Actually, it's interesting. One of the points David Patterson made on his talk in Gamrick was not only should we be talking about it as being an antimicrobial resistance problem, it's an antimicrobial resistance and access problem. So many of the countries that are included in this study may not have had ready access to Keftaz-Avi and the newer antimicrobials.
The timing of this and evolution of drug resistance to this particular compound is also different today.
The comments that came up about standard of care is not necessarily the same everywhere. And it can be for a number of reasons, including lack of availability in certain countries of actually compounds that might be needed to manage the infections that they're seeing. But it's still, on a technicality, standard of care. The problem is that then the results don't generalize to other environments where the standard of care is different. That makes these things complicated, but also emphasizes a problem with standard of care in certain countries.
And your point, Josh, about the source control, you're right. Actually, in the discussion, they have quite some relevant points about that, including the IVs and intra-abdominal sources. So that's all very pertinent. But I suppose notwithstanding, it's a huge trial. Like even to get people enrolled within 48 hours, that's pretty fast. I listened back to your first podcast, and one of the speakers made the point that maybe we need to start using the adaptive platforms because we need bigger numbers to answer the question. Because I don't probably need clofidricol for most of my gram-negative bloodstream infections, but I might need it for some. At the moment, we don't in our own hospital have in-house testing, but we send it off to our colleagues in the UK, in Colindale. And with thanks to my wonderful colleague, Binu Dinesh, who rapidly got some data from me, we all had the impression that every time we sent it off, it was resistant. And actually, we were right. So in about 2 years, we sent 69 isolates off for clofidricol susceptibilities. And bar 2 isolates, most of the enterobacterales were resistant. Now, that's obviously, we don't send everything off. And a lot of these were NDMs. Interestingly, we sent 35 Pseudomonases and 9 were only resistant. But again, we're not going to use that in Pseudomonas. But in this trial, you wouldn't have continued clofidricol if it was resistant, whereas we don't have that luxury. So I think until we get it in-house for our own centre, this is probably going to be a conversation we'll be all going, should we use this or not?
Annie, I think you have some experience in your institution.
Yeah, so I mean, this paper really for me boils down to what is your local epidemiology in terms of what flavour of beta-lactamase are you seeing locally? And we've had sort of grumbling issues with NDM in our institution over the past sort of 5 to 10 years. And I think we were all waiting for clofidricol. I'm going to go with clofidricol to come. We were waiting, you hear it at conferences and we were like, it's nearly here. We've got such an NDM issue. We can't wait. We're sick of trying to do these combinations of ceftazidime and aztreonam and aminoglycosides, and pretty much everything we see now is resistant. Our NDMs are all resistant. That really rings true what you were saying. And also testing is not easy either. I don't know, Robin, if you want to make a comment about the practicalities, difficult testing in terms of whether you can reliably use this or not. And testing guidance has changed a fair bit over the past few years as well, hasn't it?
The points are interesting. I'm guessing, Annie, that you hadn't used a lot of this compound, and yet you're describing high rates of resistance in exactly the organisms you wanted to target. And
exactly,
that's one of the challenges with antimicrobial resistance is you would think that having not used it in your clinical practice, you would be good to go. But in fact, that's not the case. And we're seeing that from some of the work that we're doing in Europe as well. So that's a challenge. And then the susceptibility testing to this agent is also challenging because of its mechanism of action. It needs special media for testing, and that's not universally available. And so you don't even have that information. So now we have resistance that's already arrived ahead of using an antibiotic in clinical practice and challenges with availability of susceptibility testing. The other thought is that we do need still more implementation of diagnostics to tell us what drugs to use to treat gram-negative bacteremia, because we have now rapid diagnostics that can really inform that. There's been a huge explosion on the phenotypic susceptibility testing side to make those results available rapidly. I think for idealized patient care, that would be the way to go. Obviously, there are logistics and expense involved in that, and they're probably not available from a regulatory standpoint everywhere, just like we talked about with the therapeutics. But I think globally, we have some solutions in our toolbox that we're not necessarily deploying, and we're also learning that in many cases, the horse already got out of the barn before we even got to thinking about what we're going to do in our own clinical practices. So it's a great conversation, complicated.
Yeah, I should say most of our NDM infections are imported. We're kind of seeing resistance coming into our institution, but then spinning off and having our own little outbreaks to deal with as a result. So yeah, a tricky one with clofidricol. Okay, now on to Robin's last chosen paper. I have to say, this paper really is the coolest. I actually came across it listening to an anthropology podcast a little while ago. So when I saw that you'd selected it, Robin, and you sent it through, I was like, oh, yes, I knew I'd heard something about this. So it just combines everything. There's got microbiology, archaeology, paleoanthropology, whole genome sequencing, and randomly the squirrels of the British Isles as well, all in one. So it's got a lot going on. Robin, Can you unpack this one for us?
Absolutely. So first of all, let me explain a little bit about why I personally chose this, because I mentioned I chose all my papers because of a personal connection. So in 2017, we launched our 16S ribosomal RNA PCR sequencing assay. And one of the first tests that I reported out was a patient with leprosy. One of my colleagues had diagnosed, and they said, oh, hey, can you run your fancy new test on this patient's skin biopsy? And I said, why? You know what's going on. They have leprosy and it's caused by Mycobacterium leprae. So what question am I answering that's going to help you in this diagnostic odyssey? They kind of said, well, just because you have this cool new assay. And we hadn't specifically validated the diagnostic for diagnosis of leprosy, although bioinformatically we knew it would work. So my arm got twisted and we ran it. And then I got the results back and I looked at the sequence data and I was like, wait a second. It's not Mycobacterium leprae. It's Mycobacterium lepromatosis, which caused me to say, and I'll just be honest, what is Mycobacterium lepromatosis? Because I had never heard of it. The sequence data was clear, by the way. It was not Mycobacterium leprae. It was very nicely separated by the assay we had designed, despite the fact that we hadn't designed the assay to make this distinctions, which is also really cool and highlights genomics. So this, in a way, answers some of the questions of what is Mycobacterium lepromatosis, and also tells some interesting stories, as you point out. So leprosy, we know a lot about as physicians. It was discovered by Hansen in Norway in 1871. It's caused by Mycobacterium leprae, and it was the sole cause of leprosy, actually, until 2008, when Mycobacterium lepromatosis was identified in 2 patients with diffuse lepromatous leprosy in the U.S., who were from Mexico. Also interesting here is that the consensus is that the introduction of Mycobacterium leprae into the Americas was a consequence of European colonization. And that's a story that we tell over and over again. But interestingly, most cases of Mycobacterium lepromatosis have been identified in the Americas. And so this, right off the bat, suggested a different possible origin and epidemiological path. What is this disease? A 2023 review identified 27 cases of Mycobacterium lepromatosis infection, 19 from North America, 10 found in the US, but 7 of those 10 patients were originally from Mexico, 6 in Mexico, 3 in the Dominican Republic, and 1 each in Paraguay, Cuba, and Canada. In addition, there have been 2 reported cases in Singapore, 2 in Myanmar, and 1 in Indonesia. Clinically, of the 27 patients, 15 had diffuse lepromatous leprosy, 10 had lepromatous leprosy, and 2 had borderline lepromatous leprosy. So this study was published in Science, and it's called Pre-European Contact Leprosy in the Americas and Its Current Persistence. It's a nice title. It really kind of tells you the whole story. So Lopopolo and colleagues investigated the evidence indicating that Mycobacterium lepromatosis initially emerged in the Americas, rather than having been introduced via European colonization like Mycobacterium leprae. They found Mycobacterium lepromatosis DNA in 34 samples. They looked at leprosy samples across 5 countries in the Americas, the US, Mexico, French Guiana, Brazil, and Paraguay. And then they combined high-throughput short-read sequencing and targeted enrichment and were able to recover genomic data from 23 of 34 positive samples. Interestingly, technologically, they overcame limitations of short-read sequencing by generating high-quality long-read Mycobacterium lepromatosis DNA from mouse footbed samples inoculated with the strain from a human sample that came from Costa Rica. They then also went on to examine a collection of 389 ancient DNA datasets from pre-European contact ancestors in the Americas, and they recalculated the time of divergence between Mycobacterium leprae and lepromatosis. This had been previously calculated. So these are modeling, and in one model, the most recent common ancestor was 720,000 years ago in the Pleistocene age, and in a second model, it was 2 million years ago in the late Triassic. In either case, divergence happened a long time ago. This apparently was sooner than prior estimates. They also looked at the remains of 3 human American ancestors who tested positive for Mycobacterium lepromatosis. 1 was from Canada and 2 were from Argentina, and they were dated by radiocarbon to a time approximately 1,000 years ago. So that is before European contact, and they indicate a genetic ancestry that's indigenous to the Americas. They also went on to combine that ancient and present-day DNA data to look at clades, and they found 5 clades of Mycobacterium lepromatosis, 4 which were first detected in the Americas, and now we are getting to the squirrels, Annie. The 5th clade was identified in red squirrels in Britain and Ireland in 2016. But even though that's where it was found, it was subsequently shown to belong to an American lineage that had been likely introduced into the British Isles toward the end of the 19th century. So we're actually taking this organism from the Americas over to the British Isles, which is interesting. Of the 26 present-day strains analyzed using maximum likelihood phylogenetic reconstruction, all but 2 belong to a single present-day dominant phylogenetic clade that was near clonal. So analysis of ancient genomic DNA and phylogenomic evaluation clearly demonstrates that Mycobacterium leprae was brought to the Americas from Europe and Asia, but this work now provides definitive evidence that Mycobacterium lepromatosis was endemic in the Americas before the arrival of Europeans. It also shows that it was geographically widespread across the Americas. So this study shows the value of ancient genomics to understand the history of infectious diseases, but also, I think, highlights yet another bacterium beyond Kingella kingi, Streptococcus dysgalactiae, that is likely underappreciated by clinicians. So hopefully everybody now has heard of Mycobacterium lepromatosis.
Wow. I really enjoyed this. I really enjoyed going back and reading more about leprosy. And again, in the US, we don't see it very often, if at all, some people in their practice. And the fact of the matter is that in some countries like India and Brazil, for example, they have 10,000 cases a year of this. And that's really remarkable. It shows that we need to take better note of where our patients are coming from, and because of global travel, where people are going, and also just to continue to read and learn lifelong when we are in these areas of work.
And I think also it speaks to diagnostics, right? Because I began with someone asked to run an advanced diagnostic, and I was like, why? You already know the answer. And then it turned out that it wasn't the answer that I thought it would be. So I'm not suggesting we need to go crazy and using molecular diagnostics, but we learn a lot by using molecular diagnostics. This is just a great example of that.
I love that it kind of overturned that assumption that everybody thought they knew. We've kind of touched on that a bit. Everybody thought, oh, well, the Europeans took it to the Americas. And I just love that we can use science to try and find the truth to things. And how amazing is it that sequencing has come so far, even in the past decade? It's just beyond what people would have imagined possible, isn't it? I'm so excited to know what else we're going to unpick. What diseases are we going to find the origins of, I think?
If you look at the list of contributors, they are from all over the world. It's truly an international collaboration. Amazing body of work to pull everybody together and execute the sequencing analysis that was done. And I mentioned mouse foot pads were also involved in this work. So there was a lot going on the technical side and on the collaborative side.
I think that foreshadowing the future, looking at epigenomics is another step even. What would you do that for? Well, to define why one strain might be more virulent than another, or what changed to allow the hop to the red squirrels. So I think this is really the tip of the iceberg for where we're going to be going in the next several years.
And I think that's a great example, Robin, of storytelling and illustrating how diagnostics, it's a bit like CSI, if I may use an example. I could almost see that you were telling a story there. So when we start talking about communication, that would be an amazing way of demonstrating the use of diagnostics. In my head, I could see just a TV program or a cartoon, and it could be used really good educationally because it's such a good story.
The issue of communication is a beautiful segue into our final paper of the 2025 Clinical Microbiology Top Picks. Fidelma has chosen an opinion piece from ASHE rather than original research to round things up, and it gets to the point of communication. Fidelma, can you take us into the echo chamber?
It's called Beyond the Echo Chamber, Reframing AMR Awareness Efforts to Reach the Other 99.9%. So I like the idea of clear communication. And in a way, I'd summarize that title of It's Not What You Say, It's How You Say It. And the paper quite rightly makes a point that we're all specialists in infection and we're very passionate about addressing AMR, and we talk about it a lot and we write about it a lot and we talk to each other about it a lot. But this kind of enthusiasm is essentially self-contained most of the time to all of us. So we're talking within an echo chamber and we're really scratching the surface of the public or other clinicians and policymakers. And actually, these are the people that are going to get us a bit of traction. So the 99.9% refers to the fact that infection specialists are less than 0.1% of the population. So we're targeting the others. What the paper talks about is various public opinion surveys. About a quarter of people have never heard of AMR. And then when they've heard of it, they really don't think they can do much about it, and over half of them, which is kind of shocking and to me has parallels with climate change. This is such a big problem that when it starts involving everybody, when you're a little old me, you don't really know what you personally can do. But they also make the point, which is kind of a reality check for me, and I know it because I see it every day, is most healthcare professionals, while they might understand it, they're kind of at best ambivalent about AMR because they've other priorities like obesity or diabetes or cigarette smoking or whatever. And like certainly since I started in clinical microbiology in the mid-90s, there's been a sea change in terms of awareness politically. We might say not enough, but at least there is. It's been discussed at the UN. But I think generally most of us would agree that all these commitments and documents probably haven't been matched with consistent funding and consistent policy instruments to see them through. I think if we look at AMR in the whole One Health perspective, there's lots of competing interests. We have surveillance systems, but there are a lot of them are incomplete. We don't have consistent coordination across sectors. There's lots of regulatory gaps. There are still places in the world you can go and buy your sweets and your antibiotics at the same time. The role of science is under threat internationally, and it's becoming very much eroded using science to make decisions. And we kind of don't help ourselves either because AMR is not an easy thing to get across. It's complicated and it's very nuanced. So it's not a very straightforward message. And the other thing is if we're trying to engage policymakers, the political cycle is very short. It's certainly very short in Ireland. We have general elections at very frequent cycles. And to get some kind of traction on AMR, you need long-term planning and long-term investment. So if you're a politician, well, why should you focus on that where you can get a lot more kudos on something like improving your trolley weights? So what this paper does is takes all of this and goes, what can we actually do? They picked 4 areas, and the first is knowledge translation. And it's what we've been talking about. And it's what I said to Robin about that story. We need to be able to translate our message in different ways, I suppose using different languages to different audiences, and appreciating that some people can read, some people may not. Some people find visuals more helpful. Some people want the snappy answer. So we have to kind of get better at translating our message into very clear, simple, and I suppose actionable things. Investing in public engagement, that's the second one. There has been public information campaigns, but there tends to be a tendency, oh, we've done that and it's over. But that's not true. We have to constantly keep kind of highlighting that we need these public information campaigns. We need clear messaging, but it needs to be actionable. Otherwise, the individual gets lost in the complexity and it's very easy to go, what can I do myself? Then the other 2 parts are leveraging One Health. We talk about that a lot. And actually, in many countries, including my own, there's been huge advances in the One Health dialogue. And in Ireland, we are now on our 3rd National Action Plan for Antimicrobial Resistance. So that's fantastic. But we need to continue doing that. And then the last thing, which I think is important, specifically as we start the new year in 2026, is we have to get science and policy partnerships. We just simply have to do that. We have to co-develop things. We have to get AMR understood by our policymakers, use some kind of language that we can all get. And certainly at last year's estimate in 2025, the AMR Science Policy Forum, which I attended, I thought was really exciting. So you had all the appropriate people around the table, and that's where the discussion starts. I liked this paper because it got me thinking, and it reminded me we're doing what we're doing on this podcast. We're talking to ourselves, and presumably the people that listen will be infection experts. But probably what we need to do is do a different podcast sometime for the general public and go through all these papers and try and explain them in plain English. And I think Robin's story is probably going to be the one that the general public will like the best. But I might be able to give her a run for her money on the dots and the door criteria.
The line that was most powerful to me is that AMR is a shared problem, and I really like that. At the same time, I will say that many people, even in infectious diseases and clin micro that I talk to, you bring up AMR, they talk about antibacterial issues. And AMR is bigger than that. We have antivirals that don't work for complicated herpes. We have malaria drugs that don't work, and we have antifungals that don't work. And I think it's on us as a community to make sure that we bring that as a shared problem together, because we're much stronger when we include everybody in these discussions, regardless of whether it's a eukaryote or a prokaryote or a virus. They are all causing devastating problems globally, and we need to have a very clear voice on this topic.
Mm-hmm. And I think we need to get better at telling stories. So locally, when I'm teaching about AMR, I pick a patient with a problem and demonstrate the problem through the patient, because otherwise it's not tangible. I think we have to get better at being more inclusive ourselves, as you rightly point out, and then broadening it out first to our own colleagues and then broader still, because we tend to talk about the policymakers, but actually between us and the policymakers are the electorate, and they tend to kind of influence the policymakers as well. By engaging the public, we are the public, but the non-specialist public, and listening to our patients and trying to bring them into our discussions and our research, I think the conversation and the action can be all the richer.
I think that we as scientists, we're also very poor at communicating our science with the public. Maybe we just aren't doing it that much, but we're also very bad at it. And so we need to reflect on how we can do better there. Maybe it's our younger folks who can really help us and think about how they would do it and try different approaches to doing that. I also wanted to thank you again for picking dots. I think thinking about trials that really take a patient perspective is important, because all of this is that echo chamber of talking to ourselves, which we're doing here today. And we're really nerding out and we all love it, right? That's great. But for the people that we're really trying to help with what we're doing, they're not involved, and they need to be involved, because that's the whole reason we're doing this in the first place. So thank you for picking the articles that you did, and especially this last one.
Great. That's it for the papers. Josh, out of the papers we've discussed, which one had the biggest impact on you?
I easily would say the leprosy one. And I really agree with Fidelma when she said it could be made into something that we could watch. And I really was looking at it more like a Raiders of the Lost Ark type of thing. And I don't know, Robin, if you would play the lead there, but I think it would be an incredible way of showing how history matters. I was a history major in university, and so I always go back to what did we know about this and how come we didn't do better? And so this is an area where we've learned a lot and can continue to do better. So it's very exciting to me, and I really appreciated all 6 of the papers, but that one was a standout for me. What about you, Annie?
I do have a soft spot for the paleomicrobiology paper, so I think probably at my heart I'd say that one. But I do think the Strepdisgalactiae subspecies sequisimilis paper is going to make me think a little bit more in my own practice, because we see so many of these. It's so common. It's usually elderly, frail patients. It's our bread and butter as microbiologists and ID physicians, and it's just going to make me think a little bit harder about whether I've been underestimating that as an invasive infection.
Well, we certainly covered a tremendous breadth of clinical microbiology, and I do want to give our amazing, amazing guests the opportunity for some final thoughts. Fidelma?
I think that my point about AMR and communication is what I'd like to take home for myself, and it's not just what you say, it's how you say it. And we need to engage different audiences and be consistent in our message, and remember that the AMR is antimicrobial resistance. Thank you all. Thank you, Robin, and thank you to Josh and Annie for inviting me.
Well, thank you, Fidelma, for the kind words. It's a pleasure to do this. And These articles are all great, and there are many more. I picked mine from personal experience and also because they really reflect things that we thought to be otherwise, new knowledge that maybe is going to change some of our practice or the way that we care for our patients. And I think they also emphasize that we need more science, right? There are things that we don't know. We need to continue to investigate in these areas. What's the right diagnostic for the right patient? What's the right therapeutic for particular patients? And then, importantly, Fidelma, your perspective on what does the patient actually want? Because a lot of times we take our own perspective. I know best because I'm the expert. But actually, this is about our patients. So what do they want?
That's our top clinical microbiology papers of 2025. And we'll, of course, link to all of the papers in our show notes so that listeners can check these manuscripts out for themselves. Thank you again to our guests, Robin Patel from the Mayo Clinic in Rochester, Minnesota, and Fidelma Fitzpatrick at the Royal College of Surgeons and Beaumont Hospital in Dublin, Ireland. And thank you for listening to Communicable, the CMI Comms podcast. This episode was hosted by Josh Nosanchuk in New York, USA, and me, Annie Joseph, in Nottingham, UK, Associate Editors at CMI Comms, ESCMID's Open Access Journal. It was edited and produced by Dr. Kathryn Hostettler and peer-reviewed by Dr. Sinéad Kilgarriff of the National Virus Reference Laboratory, University College Dublin in Ireland. Theme music was composed and conducted by Joseph McDade. This episode will be citable with a written summary referenced by a DOI in the next 8 weeks. And of course, all our papers and any other literature we've discussed today will be linked in our show notes. You can subscribe to Communicable wherever you get your podcasts, or you can find it on ESCMID's website for the CMI Comms Journal. Thank you for listening and helping CMI Comms and ESCMID move the conversation in infectious diseases and clinical microbiology further along.